to share a lot of the work that these teams have been doing.
So we're going to take a little bit of a retrospective look at 2020. It's been quite the year, obviously. And so we'll start out with the January 24th New England Journal article. So if you recall, this was the first description of the novel coronavirus. I don't remember where I was January 24th, but I do remember where I was in February. So everybody should remember that first news article, the report that Miramar was going to be the site for quarantine of a plane from China. You can see this was February 2nd here. And if you remember, on February 7th, there was another plane, a second flight that came in. And February 10th was the date that we heard that some of the evacuees were testing positive, and that UC San Diego was actually going to be the site of the first positive patient in San Diego. And subsequently, the group that cared for that patient actually wrote up a case report. So this came out in June. You can see some folks from hospital medicine there, as well as infectious disease and infection prevention on that description of the 51-year-old Chinese woman who was on the plane evacuated from Wuhan. And they describe her clinical course. Fortunately, she was discharged relatively healthy. But I think one of the important things about this report was that because UC San Diego had COVID patients in February, we were forced to put in place a bunch of processes and policies and infection prevention efforts and informatics efforts that really helped to prepare us when the tsunami came. And of course, the tsunami, started in March. I actually remember I was out to dinner the evening of Wednesday, March 11th, when the World Health Organization declared COVID to be a pandemic. And I was at a dinner where we were planning a camp out for the following weekend. And when I got this news, I said, guys, there's a good chance this camp out's not going to happen. And they said, nah, we're still camping. And then later in the evening, I said, the way I'm reading this, there's a good chance our kids aren't going back to school on Monday. And that was Wednesday night. By Friday, the federal emergency declaration had been issued. And of course, I think most people remember that weekend because it was a time of a lot of uncertainty, anxiety, and for many of us in the health system, work. So we'll talk about what happened that weekend soon. But one of the really important things I wanted to highlight happened that following week, the week of March 16th. And that was the beginning of tiered daily huddles. So we've been doing weekly huddles in information services for some time, also in the quality department. But we decided that week of March 16th, I think the first huddles were actually March 18th. And we started using this approach that our colleagues in health transformation put together for us, a very structured approach to daily huddles. Many of our medical directors are on the medical director huddle that used to be daily, now is twice weekly. But I think few would argue that these huddles have provided a real new approach to structured teamwork that enables more rapid decision-making and more rapid both escalation of issues and cascading of information. And so as we'll talk about at the end, I think this is one of the things that we're going to see sustained post-COVID at UC San Diego. And a lot of the work that I'm going to talk about today, I really credit these tiered huddles for helping to enable in such a rapid fashion. So the following week, March 24th, we actually had a manuscript published. And this was an unusual experience that I never expect to happen again, which is that Dr. Jeff Reeves, one of our surgical residents, he had a little bit of time on his hands. Most of the ORs were shut down except for urgent cases, and many people were working remotely. So we gave him a bunch of data, and he wrote up a fantastic paper. You can see our middle authorship includes Francesca Toriani, Randy Taplitz, and Shara Abeleys, all infectious disease physicians from our infection prevention team. And then Marlene Bryan and myself also representing the information services group. And we submitted this manuscript, it must have been like March 21st or so. And the editor, Sue Bakken, wrote me back 47 minutes later and said, accepted. There were no edits, no revision requests. It literally was submission to acceptance in less than an hour. The paper's now been cited 80 times because it was the first manuscript to describe optimization of health information technology to support the COVID pandemic battle. So I'm going to take you through some of the things that we described and, of course, what's happened since then. This was the table where we described different tools integrated in our electronic health record for managing a pandemic. And I have to admit, we weren't particularly forward thinking, but a lot of this in retrospect seems quite prescient. So for example, we talked about screening protocols, but at the time that this was published, a lot of those screening protocols were things like, have you had international travel, right? So remember, we put that into the electronic health record to help our front desk folks screen quickly for that. But obviously that changed rapidly. And so some of the screening protocols that we have in place today are daily symptom screening for all of our students and our employees. And so I want to give a big shout out to Josh Glandorf and Andrew Greaves, who've put together this screening tool that most of us use on a daily basis. And it's actually getting, I think the employee screening tool is over 10,000 uses a day. The student symptom screening tool is similar use. So just tremendous adoption. It's mandated for anybody on site by the County of San Diego Public Health Order. And then it's strongly encouraged for those offsite. And one of the things that is not immediately obvious on the front end when you're using this screening tool is how tightly this is tied to the back end. So this supports the testing process, but unlike a lot of the screening tools out there where, if you screen positive, it gives you a number to call. In this case, if you screen positive, right, it automatically alerts your supervisor, and it also automatically alerts our COVID testing team. And in fact, I've had this example of screening positive once over the last 6 months, and I had a call within like an hour of screening. They called me, which is pretty convenient. We've got a quote here from a patient who said, or an employee patient who said, I received a call from the testing scheduling line within 30 minutes of taking the survey. I took a PCR test less than 3 hours after doing the screening and was notified of the results in less than 10 hours. And this is the type of really remarkable results that these tools are supporting, from a full process standpoint. And you can see all the different permutations like of the student tool there, where you've got yellow, red, and green thumbs and testing compliance and other things. And the wording has to be exact, and HR has been involved, and our employment lawyers have been involved. And so, their health system is supporting the entire university in this process, including student athletes, which in itself is a story. Another way that we mobilized very quickly was around our emergency department and inpatient and ambulatory order panels. And I want to give a shout out here to our leaders on the EPIC team, Dean Pham, Alan Tran, Maria Perez-Clegg, and Judd Simons, because they all came together and really helped to make these things happen. And in fact, it really supported our return to learn testing pilot, which occurred in May. So that was when we took 1,500 students and we had them doing self-tests for the first time ever, because all the testing prior to that had been at testing collection sites by nursing staff and other clinical users that actually had PPE on it. So in this case, this was an observed self-test, and helped us work out a lot of kinks in the system for the full return to learn this fall. In fact, I just came off a call about our return to learn program, and I learned that enrollment at UC San Diego is higher than it has ever been. We have 800 students more registered this fall than we did last fall, which is really, pretty amazing if you think about the environment that we're doing that in. And yet, as we'll talk about in a minute, we've brought more students back to our university than any other university in the state of California and any other UC. So we've seen enrollment is down at a lot of the other UCs, including Cal Berkeley. That's not been the case for us. And a lot of credit to this, return to learn program that was envisioned in the spring and supported by a shared electronic health record across student health and our health system. So this was a journey in and of itself that started 2 years ago and serendipitously went live last summer, August of 2019. So a lot of credit here to Dr. Marlene Millen, our physician lead from health, and Dr. Angela Sosha, our former chief medical officer, who was brought back from retirement to help lead student health and well-being. And I'll tell you, having Angela over in student health during this EPIC implementation was like a secret weapon, because she understood it, she knew the nuances, and she was a great partner leading the student health and CAPS teams. So this was a blog posting about this, but some great news. We just got a word this week about acceptance of a paper in the Journal of American College Health. This is not a high impact factor journal, but it was the right journal to put this work in, because American College Health is where student health publishes papers. And so again, Dr. Reeves wrote this up for us. You see Stacy San Miguel, Reina Juarez from Student Health and CAPS, Joe Beamer and Kevin Ramatar as well, and our CEO in the authorship there, because Patty was really the one who made this project happen over a lot of potential barriers and bumps, and it was her vision. So excited to see this come out into print. Some of the things that you'll see in this article, for example, are the amount of record sharing that's occurring between our students and the rest of the United States. So not surprisingly, the #1 record share is Scripps Health here in San Diego, because we get a lot of students from Southern California. #2 is Kaiser of Southern California. But look at this, #3 is CVS, #4 is Sutter and Stanford in Northern California. And as you go down the list, there's this incredible long tail of interoperability that's occurring across the US. And it really blew my mind when we took these 40,000 students that we'd loaded into EPIC, and we started doing the Care Everywhere queries. And we got links from Children's Philadelphia and Lurie Children's in Chicago, all sorts of children's hospital. We got links from City of Hope and other cancer hospitals like MD Anderson. So our providers now have access to data and information that they never had before. And that includes our counseling providers. And we started getting stories right away of counselors, for example, who've been seeing students for years, but the students had not divulged that they were taking Ritalin or some other, pertinent medication that their primary care physicians might still be prescribing. Or in other cases, they're able to get access to information from our emergency department, et cetera. We didn't even know how many of our students were coming to our emergency department and our clinics beforehand, because a subset of them do have SHIP insurance, but that's all we could get. If you were a student on your parents' commercial insurance, we had no idea, no way of knowing that when you came in. So now we have much more accurate information, and that's all described in this article that I think is going to really change things across the face of the country, because this should be a model, frankly, for every university student health that has a health system. And for those that don't, they should be looking at sharing health records with local health systems. We described things like turnaround times for radiology results increasing. But the behind the scenes story on this is even funnier, which is that our radiologists at UCSD Health do these reads. But formerly, there were teleradiology reads. There was one workstation in neuroradiology, and any x-ray that was done in student health was read by neuroradiology. So I see Dr. Shao there from radiology. I'll tell you, the student health team had gotten very used to this one neuroradiologist that read all their films, chest films, wrist films, it didn't matter. He read them all around 4 o'clock before he left. And so they had this complicated system of wet reads and how to get preliminary reads and things like that. After we put them onto EPIC, including the Radiant information system, they were also on our shared AGFA PACS. And so the films just went into the hospital work list. They get read in an average of 5 to 10 minutes. And there's no longer a need for wet reads, and the satisfaction's really gone way up. So thumbs up from Albert. So on the reporting and analytics side, a lot to report here. And I want to give a big shout out, of course, to Jennifer Holland and her team, as well as to Ema Himmen and our quality team. But the COVID daily readiness dashboard, this is a screenshot from the paper. You can see it was March 17th of 2020. That was actually a screenshot we did right before we submitted it. And it was, that paper was approved on March 17th, published 7 days later on the 24th. And so you can see certainly some things a little bit the same. Our visits much higher now, obviously. Our way of showing where patients are is similar. But this graph here, much different and a lot more information on that. So this is our dashboard as of yesterday. You can see 4,000 visits with 20% telehealth rate. We've got 1,700 results yesterday, of which 9 were positive for COVID, and 20 patients in-house currently. I love this graph right here, which shows since the beginning of March, the number of in-house COVID patients that we've had. And of course, a little spike, potential resurgence coming up. You also see the data from the screening tool now up to 12,000 on Wednesdays, as well as where those screenings are being done and where they're screening positive, right? So interesting data. And then this is the COM versus the Excite lab. So another interesting backstory, but credit to Dr. Brenner and others for the vision of making sure that the health system lab wasn't the only source of capacity for testing. And so in the blue, you see the COM lab run by Dr. McClaw, Dr. Gonius. In the yellow, though, you see the Excite lab. I forget what the acronym stands for, but I think they chose it to highlight the contrast. They're running this in 3 different researchers' labs, Dr. Rob Knight, Dr. Luis Laurent, and Dr. Jean Yao. And they're using homegrown lab software that we brought in a third party and actually interfaced that to Epic, which is why it shows up here in our analytics and why we can use the student health Epic testing order workflows. A lot of credit to Mark Silvestrak and the team that did the Epic integration for those results. It's allowed our capacity to expand dramatically. Most of our on-campus students are being tested in the Excite lab now, and they're maintaining turnaround times as good as the health system lab at less than 24 hours. Now, there was an article this summer about the COVID dashboard at UCSD Health. And one of the things I really highlighted in the article is that every health system at this point's got some analytics dashboard, and some are prettier than others. UCSF did a really good job, I think, of leapfrogging us, and then we took some of their ideas. So I don't think it's novel having a dashboard, but I think there are 2 things that are novel about UCSD. One of them is that we got this up so quickly, and we talk about that weekend of March 13th. And I know that Jennifer and her team were working over that weekend because we were going back and forth on iterations of that dashboard. The second thing I think that's really novel is that that dashboard created by Jennifer's team was going out to the entire executive team within that first week after the declaration of a national emergency. By the second week, we had rolled that out to the entire medical staff because we said we want to keep our physicians informed on what's going on. And by the third week, Patty and I had a conversation and said, is there any reason not to be transparent across our entire health science employee base? And we did that. So every day, 18,000 employees get this dashboard. I know all of you get it. I remember a couple conversations, from the risk folks about, well, all of our students are going to get it. And I said, well, that's great. We want their students to be part of this community as well. And so I really give a lot of credit to Patty for supporting this transparency. And as I described in the article, there's a lot of emails that I get responses on when they go out to all health sciences. Even just the one yesterday about Skype getting sunset and things like that. This is one email that I didn't get any hate mails about. And in fact, the unexpected positive benefits of sharing this information across the community were really overwhelming. I mean, we found directors of the nursing student program who are using it to place their nursing students daily because they weren't putting nursing students on COVID units. We found epidemiologists who were doing predictions, of outbreak in our community using some of this data. Just, really remarkable what this level of transparency supported. And that continues to this day. So we now have a Return to Learn dashboard. I'd encourage you to check it out on the Return to Learn website. You can see it shows all of our students and campus employee tests on a daily basis. And it also shows a number of positives, and you can see how low that is. In fact, it shows the county rate, which is hovering around 3.5%, as well as the student and employee rate, which is around 0.2 to 0.4% recently. Shows our 7-day average for turnaround time. And it shows all the students diagnosed since March 1st, but on this graph, it now shows the students since October 1st when the instruction quarter started. So compare the 28 we've had since starting to the over 1,000 that some of our sister universities have had. And clearly, you know, something's been done right, not only by the Return to Learn program and the protocols and policies that have been put in place, but also by our students, who deserve a lot of credit, I think, for adhering to masking standards and other things like that. One of the interesting things that our Chancellor, Dr. Khosla, was very engaged on was making sure that we were able to display data about students living on campus versus students living off campus. And so here in the light blue, you see the off-campus students. Now remember, on-campus students are required to test every 14 days, and Andrew baked that into the symptom screening tool, so it's really a health passport. Students that are living off campus are required to test if they're coming to campus, and then it's optional if they're living off campus. And what you see here is that in the last 4 weeks or so, there's actually about 2-to-1 rate of off-campus students getting COVID compared to on-campus. Probably too early to draw conclusions yet, but when you think about some of the safety net on campus around wastewater testing, which has already caught one outbreak before it could become larger and track down to an asymptomatic employee, there's probably some merit to the idea that campus is a safer bubble from a living standpoint. Now, we did have a dashboard that initially was only being updated on a weekly basis. And again, Jennifer and her team getting the data over to campus to update this on a daily basis. So Natasha Martin was really proud when the ratecoviddashboard.com website bumped us from a C to an A. And in fact, here, this is sorted by the Big West Conference, where you can see we're the only A. We're also the top rated dashboard in the University of California, as well as the state of California, although Berkeley's catching up quick, so we got to stay ahead. But it's good, this level of transparency. Now, the next thing that our paper described as being important were communication channels. And we talked a little bit about tiered huddles already, but I think this EHR integrated secure messaging was an underappreciated rollout. And I really like this paper that was published as a perspective in JAMIA by the Vanderbilt group. And it was this concept of electronic PPE. So how could you use, video visits, not just in the outpatient setting, but also potentially the inpatient emergency department and other tools to help avoid unnecessary contact. Obviously, we still want our doctors and nurses in seeing patients when necessary, but there's a lot of conversations that didn't have to be done in person. And so we did roll out a EHR integrated secure chat tool across all of our nursing staff. And Judd, I couldn't find a picture of you, but credit to Judd and Brian for this rollout. We had done a pilot already in the newborn area, but we were sort of slow rolling this because of a lot of concern around how this might impact physicians and nurses. Some of that's come to be, but we were able to make a rapid decision around rolling this out because of the importance of preserving PPE and unnecessary inpatient contacts. In fact, this was built on top of my clinical team, so I want to give credit to the newborns. Judd and Brian are also co-authors on this, but it was led by one of our nurse practitioners in the pediatric service who has actually got a poster she's presenting about the impact of secure chat in our clinical service, where it saved a lot of time and effort and decreased pages. So Dr. Shao is reading there, but he'll come back for this artificial intelligence section. Thanks, Albert. So this was a fun story. Albert and his colleague, Dr. Hurt, who's actually a radiology resident, along with Seth Klierman, published this. This was published in May, but I know, Albert, that had been accepted and e-published earlier. And what they described was a deep learning algorithm that they had already used for pneumonia localization applied to some films with COVID from China. And so Albert came to me, actually I think emailed me, but we had our first meeting on Friday, March 13th. I went back, Albert, and I looked at that meeting on my calendar and like who was there. Alex was there. I remember we met in the Jacobs Medical Center, and it was just as, the proverbial shit was about to hit the fan. And Albert said, hey, here's our preliminary results. We think that this algorithm can really be helpful if applied to films. And so real team effort here. From that preliminary meeting on March 13th, I think a week later, It was a soft go live, and it was fully live in production 2 weeks later on March 28th. Andrew helped me pull those dates out. And I want to give a shout out to a bunch of folks here, but in particular, Mike Hogarth and the clinical research IT team really helped to make this happen. And I would normally not pitch any vendors, but I will say Amazon came to the table on this one in a big way. So we have a good relationship with AWS around clinical research IT, and they essentially made this free for us to use. And it's a really innovative effort, because what we wanted to do from a workflow standpoint was make sure that every film that we were doing at UC San Diego was, every chest film or chest CT was processed by Dr. Xiao's algorithm, but available in our 25-year-old PAC system. And so to do that, these guys, with Band-Aid and duct tape and elbow grease and grit, figured out how to trigger a film that was taken with one of these modalities, getting uploaded to the AWS cloud, where the algorithm that Dr. Xiao and Dr. Hurd had put together was moved into the cloud. It would process the images and then send them back to our local PAC system. And it did it all in 60 to 90 seconds. And it's really remarkable that as of September, we've processed over 50,000 images from over 16,000 cases. And you can see our Amazon costs there are affordable. And I don't know what DynamoDB being in the free tier means, but Andrew thought that was important. So really remarkable outcomes. And by April 7th, we had issued the press release on this. I think AI is like catnip for journalists, because it got picked up rapidly, and probably more press than I deserve, but not enough for Albert and his team. Really got a lot of attention. And I'm proud to say that we now have an article in press about this. And so one of the places where we thought this would make the biggest impact was in the emergency department, where decisions are often made before radiologists can even return wet reads. And so Dr. Christian Demif, who's one of our faculty members in the emergency department, also with an appointment in Department of Biomedical Informatics, is a senior author on this. And he recruited another resident, Dr. Morgan Carlisle from the emergency room, who led this survey-based study. And fascinating that emergency physicians were surveyed for their experience on 202 of these different chest films. Over 85% strongly agreed or somewhat agreed that the intervention was easy to use, which was good because that's what we had designed. But then 20% of respondents reported that the algorithm impacted their clinical decision-making. And I think this is really remarkable. And this is a good lesson for our Med 264 students, because when you look at CDS algorithms, and Dr. Rob Elkara, who chairs our CDS committee, will tell you a positive predictive value of impacting clinical care or a clinical decision of 20% is out of this world. You know, a lot of our CDS alerts are designed for high risk, low frequency situations, but they're still overridden in 19 out of 20 cases. So the fact that this potentially impacted 20% of clinical decision making, in my mind, is really remarkable. I'm excited to see this article in press. And I would also share the story of the week after this went live. Amy Radnich and I were walking through the emergency department. I want to give a lot of credit to Amy and her team as well. Maybe next time, Amy, I'll replace the AWS picture with picture view. But we were in the ED and we were chatting with one of the mid-level providers in the ED, and we asked if they had seen this new colored, X-ray. Yeah, just yesterday we had a older gentleman come in, some heart failure, got a chest film, not for any respiratory symptoms, but we saw some color on the film, so we decided to order a COVID test, which we weren't going to do otherwise. I said, well, what happened? She said, actually, I didn't look. And she pulls up the chart right there and says, oh my God, it's positive. And of course, our great COVID testing team was already following up with that patient who ended up being admitted later. But that's a great example of how a COVID diagnosis was made earlier than it might have been otherwise because of Dr. Xiao's idea about putting this into production to help from a pandemic standpoint. So really huge credit, Albert, to you and your team. Thank you for being proactive there. And then finally, we described the patient-facing technology, particularly telemedicine. And I want to pause here and thank Mark Silvestrak, who we affectionately refer to as the Swizz. And you can see Mark's usually, featured full frontal in his pictures. And then we've got John Kressler and Keith Payne there, Britt and Britt, and Stacy, Lisa, and some other dude who were in the Telesprint Command Center. So this is back to that weekend of March 13th when we realized with the federal declaration that everything was going to change. So not only were we sending our employees home, but in many cases, our patients were going to go home and they weren't going to want to come in. And so this team got together and they knocked out that Sunday, March 15th, an amazing, amazing effort of training hundreds of providers in telemedicine, rescheduling thousands of appointments that had been scheduled in person and moving them to telemedicine. And a lot of credit to Mark and the folks on the telemedicine team who put this technology in place, including Dr. Brett Meyer, our medical director, because the infrastructure was there to do it. In fact, I remember calling the Epic team that weekend and saying, I would like our servers, quadrupled because we're hosted in the cloud for MyChart telemedicine. It was, well, do we need that? I said, yeah, I think we're going to. And they did it, no questions asked. And you can see here how steep that curve was. So from March 16th, that week right there, within just I guess a week or 2 short weeks, those lines had crossed. For the first time ever, we were doing more virtual visits than we were in-person visits. And of course, we had done 800, I think, virtual visits the entire previous year. We did 800, more in less than a day after those lines crossed. In the dark in the background there, you see the volume. So while our percentages increased dramatically, the volumes had fallen off. Those have now recovered largely. We're doing at or above historical volumes. And so we're now seeing that with reimbursement for televisits, we're actually able to do more care than we were previously. And that's not just on the ambulatory side, it's also on the inpatient side, where we rolled out iPad and Zoom. And I want to give credit again to the web team. They hacked together this really innovative kind of call any iPad in any patient room with Zoom solution. It's not pretty, but it worked. And I remember Dr. Sandeep Patel from oncology, who'd been bugging us for 2 or 3 weeks before we got this in place. And when he sent the note saying, worked great, I'm set, I knew that we were on the right path. I also want to give a shout out to Dr. Brett Meyer, who wrote this up. It was just published last week in the Telemed Journal of eHealth. And you can see a lot of those folks in the Telesprint team are co-authors on that paper, as well as a lot of others. Really terrific, inclusive paper. And it's a how-to article. It describes in detail how we got there, the governance, the even shows checklists, et cetera. So hopefully something that'll help others in the country as well. And I want to mention, because we talked about student health, that the student health and CAPS, also CAPS is the counseling and psychology services for students, they also benefited from it. So their lines didn't quite cross initially, but at this point, they're really more virtual than they are in person. And so remarkable infrastructure that was in place for student health to CAPS. We helped them get iPads out for their providers. And they told us the other 9 UC campuses really struggled with the approach and platforms, and that they already had this all in place. So very exciting. Brittany posted on Twitter yesterday that we're moving to context-aware linking, which will allow us to be really nimble in terms of services we use. So a lot more to come on this, but clearly telehealth is here to stay. So that's it for the paper. I wanted to move to an important topic that took up a lot of my summer, which is digital contact tracing. So I think everybody here is aware of the exposure notification system. I want to thank all of the folks that have adopted this as part of our pilot for the state of California. And I'll tell you the way this came about was that I was very interested in the technology when MIT first described it back in February as an alternative to location-based tracing, which some Asian countries were describing that they were using. By April, Apple and Google had made an unprecedented announcement that they were going to work together, like lawyers and doctors coming together, to roll out a solution that would work across both Androids and iPhones. And it was released in May. And I started making phone calls to people who knew people and saying, why isn't California doing this? And what I learned through one of our donors and close affiliate colleagues was that there were a number of folks in the state of California legislature who were quite concerned about potential privacy impact. And a lot of that were misplaced concerns that were misinformed by the fact that these Asian countries had been using location-based tracking to assist in contact tracing. So this summer, there were actually 2 Senate bills pending in our state Senate that would have outlawed any digital contact tracing. One put forward by the senator in Santa Barbara, who's a privacy lawyer by background. And they were written in such a way that they would have not allowed any of this to happen. So we began a lot of advocacy work, working with government relations, both at UC San Diego and the UC Office of the President. We finally got in front of the right people. And on September 7th, we were told, let's kick off a project. And then out of nowhere on Friday, September 11th at 5 p.m., the state dropped the announcement that they were going to do this pilot. And if you know about press releases, you know the ones you want to get attention, you drop like Monday morning or Tuesday morning. The ones that you don't want to get attention, you drop Friday evening. So it was clear that the state didn't want too much attention on this pilot. So we've been quietly working away on this. And as you all know, this is voluntary, which is in line with the Electronic Frontier Foundation recommendation. But it also is remarkably privacy preserving, to the point that it's frustrating for me because of course, I want to publish another paper about the outcomes of this. And it's really difficult to get the outcomes. We don't know the positive predictive value of an anonymous alert because we don't know if you're getting one unless you tell us. So it's incredibly privacy preserving. I think we've been through how it works before, in this cartoon, Alice and Bob are sitting on a park bench, and it's a really good illustration of where this helps the most, which is with strangers in restaurants or bars or grocery stores or college parties, somewhere where you might be unmasked but might be near strangers. So in this cartoon, Bob gets diagnosed with COVID and he enters this verification key, which is really important because we don't let just anybody attest that they have COVID. And so then within about 4 hours of Bob entering that key, Alice's phone checks for any positive keys on a centralized server hosted by the Association of Public Health Laboratories. And that anonymous key turns positive. And so she gets the alert that says you've recently come into contact with somebody who's tested positive for COVID-19. Now she could be on an iPhone and Bob was on an Android that still works, which is really cool. And credit to these companies for putting, effort, resources, technology behind this. There was slow adoption this summer. Alabama and Virginia were the first ones to go. We talked to University of Arizona and a group out of Stanford that was doing a third-party app for it. But it seems to have ramped up lately, and I'm really proud that California and UC San Diego were the first in 2 areas. The first is that all other states have been putting the verification key distribution on the backs of their contact tracers. Well, remember when we had the surge this summer that we had less than 10% of contact tracers contacting patients within 24 hours, right? I mean, I had a patient who was asymptomatic on the pediatrics floor. The baby's mom was diagnosed on admission. We all wore PPE to see the baby. At the time of discharge, 3 days later, she was still feeling great, ready to go home. County hadn't called her. So the problem is if your verification keys are being issued by contact tracers, you're way downstream and those notifications aren't going to do a whole lot. So we said for our pilot, we want to move this upstream. So our COVID testing line, which does all the testing again for students and employees, is where these verification keys are distributed. We've now distributed over 16. So we've had about 40 students and employees test positive in the last few weeks and starting the pilot. Only 16 people using the exposure notification system though. But we have had cases now of people calling and say, hey, I got this alert. And in fact, in a couple of cases, people who got the alert were telling us, yeah, I was at an unmasked gathering. And it wasn't clear if we would have learned that information if we had only contacted the people who tested positive with the historic manual contact tracing methodology. So we quarantined those students earlier than they would have been otherwise. And that's certainly preliminary data pointing to this being helpful and working. So download it now. And I want to give huge kudos to our marketing team, who you can see put this up all over campus. You all got the text message about it. There's banners and it's on the back of the bus. It's also the #1 most hit website at ucst.edu right now. And Google told us that this marketing would set the trajectory, which it did. So we're at around 15,000 downloads that we estimate, because we don't know who's running it. We're just estimating based off clicks on the website. And I want to give a big shout out to Nicole May, our senior program director, who's led this rollout across UCSD, has now been tapped because we requested expansion to other UCs, and the state said that's fine if you manage it. So Nicole is project managing expansion to 2 other UCs with medical centers, Davis and Los Angeles, so UCD and UCLA will join us, and then 3 other UCs without medical centers, so UC Berkeley, UC Riverside, and just today we got word UC Santa Barbara is joining. And the plan for those going live is mid-November, and we're purposefully waiting until we get the iOS 14.2 update, because Apple's put some tech in 14.2, allows for a couple things. One is continued piloting without that pilot profile. So that's going to make it easier for us to turn it on at other sites, which is part of the important feedback we got. The second thing is it will allow for analytics on an opt-in basis, so we can start to better understand usage. One of the interesting things is Washington, D.C. went live this week with the Exposure Notification Express. That's the one built in to the iPhone that we're using. We're the first state to use it, but Apple's now built in something that allows notification of everybody in the state that has access to it. So it's not using location-based information for tracking, just to notify you that exposure notification is available. And apparently DC has had unheard of numbers, even compared to New York, where they spent millions on marketing for their app. So that's certainly a path we're going to go down in California as we move towards statewide expansion. The key, though, no pun intended, is disseminating those verification keys. So it's great for us to do it at UCSD. UCSF followed us by a week, and they're doing it, though they haven't issued any verification keys. But to scale this across the state, we can't train every health system lab to be able to issue these verification keys. So we're now looking at how can we automate that process by hijacking the electronic lab results reporting. So every CLIA licensed lab in the state does ELR lab reporting to state of California. And that's where those numbers that the governor reports come from. In San Diego, we actually get our numbers from the state. So they reported the state first, and then the state reports back to the county of San Diego, our local numbers. And so about 85% of our messages, it turns out, do have a phone number. So we could automatically text people who are positive a key to issue. Now, we won't know if you're using the exposure notification system or not, but we think it's better just to text everybody, regardless of whether they're using it. And if you don't have the system in place, when you get that text message, it'll just prompt you to turn it on. So a lot more coming on the exposure notification front, but I think this is an exciting place that we've been leading. And in fact, the state of California has suggested that if we do roll this out across the state, that they'd like UCSD to help project manage that as well. So credit to Nicole and her team. And then finally, I think we've learned a lot around digital media. I'll say I've learned a lot because I got permission to tweet some of our UCSD health data. And so the public reporting of that has come from my Twitter account starting on April 4th. And that was followed not too long later by the University of California Health, which reports UC-wide data as part of our UC data warehouse. You can see this was from yesterday, and in the orange there, just a remarkable amount of testing. Many days UCSD is now out testing all other UCs combined, which, it's a sign we're punching above our weight. I'm proud to be a member of the UCSD community. Dr. Carrie Byington, the Executive Vice President of UC Health, reports to Michael Drake, President of University of California, and she's now commenting and sharing data as well. And then, of course, shout out to our marketing team, because the UCSD Health hashtag has been very active. And they use that to promote something that happened this summer, which of course was the virtual grand rounds. So that was a really fun experience with Dr. Chip Schooley. Chip called in favors from a bunch of his friends across the world. And we had some just remarkable talks in July and August. And together, I think those talks have now garnered over 100,000 views. So, we would routinely have hundreds to 1,000 live attendees for these talks. And then they would continue to get hits after the fact. amplifying, our effect or impact, not just within the UCSD community, not just within the San Diego community, but regionally, nationally, and even globally. So we may bring those back in the winter time. Those are under discussion now. But I wanted to wrap up and leave a few minutes for questions. And so I'll just share with you that, as we know, crisis in Chinese is two symbols, meaning danger and opportunity. And every crisis is certainly an opportunity. And so here are some of the silver linings that I've witnessed out of this. First of all, in our UCSD community, I think that this idea of grand rounds and town halls being, broadcast on Zoom is never going to recede. Being able to move from, 20 or 30 attendees to hundreds or thousands and getting people speaking from across the world, it's just remarkable. We had over 1,000 attendees on Patty's CEO town hall on Wednesday. Compare that to the couple hundred we might get at Hillcrest in the auditorium. The daily tiered huddles have been critical for rapid escalations and decision makings. And it's not just that IS and quality are doing it, it's that there's a tier 5 and the executive team is doing it every day. And so things are going all the way up and all the way down. And I don't think that's ever going to change. I think the institution has become much more comfortable with remote work. We will probably see much more of that persist. I will say in IS, where remote work was up to 3 days a week, and quality, where we were up to a day a week, I think we were better prepared than some areas of the institution where, for example, in Rev Cycle, people had never done remote work before. And so there was a lot of scrambling to support them from an infrastructure standpoint. But it turns out in some of these areas, productivity has never been higher. And even our chief HR officer says that we're closing HR tickets faster than we have before. Telehealth is clearly here to stay. I think that the big question now is what's most appropriate for telehealth. And that's going to vary by service line diagnosis. We're at about 20% overall at an institutional level, but I think that there are some areas like telemental health where we're going to remain above 90%. And Dr. Christy Calusa says the same thing for diabetes care, where follow-up visits will likely remain virtual for a long time to come. I was really proud of the fact that we moved to a single physician newsletter. So faculty, trainees, and affiliates are now getting the same message. It's a big difference from before, where we had a monthly faculty newsletter. Trainees, I think, got nothing from the institution, and the affiliates got a separate newsletter. And the fact that we're communicating in alignment is going to help our physician community be better aligned. And then this is a soft benefit, but it's remarkable, I think, that this level of data transparency is really driving decision-making in a different way. So in these daily tiered huddles in our command center, we're talking about well-informed decisions using the latest data. And so Jennifer and her team have already done a lot of thinking about how we might strategically evolve the daily COVID readiness as our COVID numbers drop, low, to more of a daily operational readiness that may still be of great interest to folks. So I'm going to stop there and I'll take some questions. The QR code is a link to my OrcID profile and a lot of this published work. And I want to say thank you again to Lucilla and Jijo for inviting me today.
Yeah, thank you so much, Dr. Longhurst. I want to invite certainly all questions. Feel free to write your question into the chat window. I'm happy to ask on your behalf. Or if you feel like your question is better posed in your own voice, feel free to unmute yourself and do so. Before we get to questions, I just wanted to quickly advertise our next week's seminars. Dr. Ming-Tai Seal, who's just an absolutely fantastic speaker, and going to be talking to us a little bit about how the electronic health record is being used to protect privacy in the ambulatory setting. But just to start off with questions, one of the first questions I see is thoughts on adding results to my chart. And I believe what this is referring to is the Bluetooth ID you had mentioned about potentially using the lab reporting system to automatically message patients about a positive test and providing them that ID through the California Notified program. How about, is that also being inserted into the MyChart messages?
Yeah, so thanks for the question, Mario. And yeah, we certainly did consider all sorts of different options for how to automate this. It would have certainly been possible for us to issue these keys kind of within our electronic health record have them right within the MyChart result like you're suggesting. The problem is when you go to scale that, right? So not all labs are, issuing results immediately through their patient portal. Even if they were, you would still have to interface this into every single lab system. And so what we're looking for is a more straightforward process. And the common process that we all do is this electronic lab result reporting. So Google, which built the key verification server, already has Twilio embedded in it for SMS purposes. So we can just take that phone number, check to see if it can actually receive an SMS, and then send one if it can. If it cannot, then we'll put that into an exception queue that will get worked by a call center team that could be centralized for the state of California. So Nicole and I were talking about this last night. If you look at our average numbers in the state of California, there might be about 3,000 individuals diagnosed with COVID on a daily basis. So let's assume that, best case scenario, a third of our population is using exposure notification across the entire state. So now you've got 15 million people using it. Of those 3,000 individuals diagnosed, perhaps 1,000 are using it. Now you try texting everybody with that positive result, but let's say that of the 1,000 individuals who are actually using the system, you're able to successfully reach 600, 800. That still leaves 200 to 400 that need to get phone calls on a daily basis, plus some phone calls from other folks that have questions, et cetera. And so we think that that's manageable to automate sort of, a level of reporting that will do the bulk of the verification key distribution, and then a call center that can help pick up the rest.
Thanks for that. And just a point of clarification. Apologize, so there was an echo. Just a quick point of clarification. I believe you already mentioned this, Chris, but the system to automatically take a positive result and send a message to the patient, just so there aren't any concerns of privacy, the individual, the patient, is ultimately still the one who has the control to share that key through the app.
Yeah, that's right. So if you get a positive test, our COVID testing line is part of their script. It's here's the symptoms to watch out for. Go to the emergency department. If you have these symptoms, we'll call you daily. And then, step number 12 is, by the way, if you use the exposure notification system, I can give you a verification key right now. Initially, we were actually giving them to them on the phone. Now we can actually automatically text those with the Twilio integration. But the code lasts for 24 hours when it's texted, and it's up to the user to decide whether or not they want to enter it and launch that anonymous exposure notification. And we've had a couple folks for whom they use the exposure notification system. We issued keys, but those keys weren't actually entered. Now, we don't know who they were, but that's the user's right.
Great. While we wait for any other questions in the chat window, number one, we just had a couple compliments. We just wanted to, a student mentioned that really the combined student health record system has been incredibly helpful to their own personal experience has been, impacted in a positive way. And the student health services often serves as a triage to direct students to more complex health needs or specialty appointments. And that has become what sounds like a much more seamless process. And certainly being a student is already a stressful time. So a big kudos to the entire team that helped make that happen.
Yeah, thanks for the feedback, Alex. And I'll say, we didn't move student health onto Epic to support COVID. That was just a serendipitous benefit. But we moved student health to Epic to support better, more coordinated care. And like you point out, there are a number of students who receive specialty care at UC San Diego. And unfortunately, in the past, that was very divided and isolated because those records were not easily accessible to the student health physicians and vice versa. And so now with the record integration, it's much better for students for their care as well as for the physicians providing it.
Thanks, Chris. And I know that at least me personally, we always take, and all of us take privacy very as one of our number one priorities. And since we do have a lot of students on our seminar, I believe there are actually special regulations that are related to student health and student health data that are separate. And I believe that's one of the issues that your incredible team really had to figure out a way to do that. But maybe you could briefly comment on that, just in case there are any students that may actually be concerned about this.
Yeah, it's a great question. So not only is all the data in the student health record subject to HIPAA, a lot of it's also subject to FERPA, which is the student privacy, student record privacy. Just like we don't give your grades out to just anybody who asks without your consent and permission. So yeah, the level of privacy that we've integrated into the records is unprecedented. In fact, it was one of the challenges of moving Epic over into student health was how to best address that. So we took a lot of precautions. We've done a lot of things differently in student health than we do in other clinics because of the unique workflows. And we've written about it in that paper that will be coming out soon in the Journal of American College Health and how we walk the HIPAA-FERPA boundary. There's actually guidance on that that's been issued by the Department of Education and HHS, because it's not just our experience that benefits from that. It's really anybody who's dealing with student health data.
Great. Well, thank you so much, Chris. I guess finally, I might just ask as the last question for any students or others who are interested in getting involved in these amazing projects. Do you recommend a point person or someone to direct any of those inquiries?
Yeah, if you're interested in getting involved, please get in touch with me or any other member of the biomedical informatics group that's involved with Health IS. So Dr. Brian Clay, Amy Sittapati, Marlene Millen, Christian Demeth, Gijo, Rob Elkere, and others.
Great. Well, thank you so much, Chris. It's a real pleasure having you on, and thank you for your time.
Thanks again for having me.